Hello, my name's Terry Cunningham. I'm the president of the Liver Coalition of San Diego. Welcome to another informational seminar dealing with liver diseases. We have experts providing very useful information. Please check our website for our list of webinars that we've been having, and also very informative webinars. The Liver Coalition was founded last year to fill the void created during the early pandemic. Now all funds raised stay in San Diego and do not go to a national organization. We'd like to thank our sponsors, without whom we would not be able to do this. And those sponsors are ASI, AbbVie, and Gilead. And we're extremely appreciative of their support for this series of webinars. I'd like to take this time. Also remember that today's webinar is for educational purposes only and should not be considered medical advice. Medical advice should only be given by your attending physician. Now I'd like to introduce Melanie Swan. I apologize. Melanie Swan from Family Health Centers, who's also on our Associate Medical Advisory Council for the Liver Coalition of San Diego. Thank you, Melanie.
Thank you, Terry. So welcome everyone. Thank you all for being here. I'll be moderating this evening. So what will happen is Dr. Schwarz is going to give her presentation, and attendees are welcome to type into the chat pod or the question section. And I will be monitoring those, and we'll get to questions at the end of the presentation. So without further ado, I want to introduce Dr. Kathleen Schwarz from Rady Children's Hospital in San Diego. She'll be presenting tonight on biliary atresia. Thank you.
Well, thank you so much for the honor of the invitation to present this webinar on what is probably the most serious liver disease of infants and children, biliary atresia. And what I'm going to do, I hope you won't regard this as cheating. I'm actually using very recent slides from the American Association for the Study of Liver Disease, put together by three friends who are experts in biliary atresia. The first is a presentation by Kathleen Schwarz on genetics of biliary atresia, which is not really a genetic disease, but people have looked hard for genes. The second is a presentation by Sunny Harpavat from Texas Children's on predictors of liver disease in children with biliary atresia. And then the last, Saul Karpin of Emory, is giving a wonderful presentation on potential therapies for biliary atresia. And we actually, it's great to be giving this talk today, in fact, because we are just about to launch one of those trials at Rady Children's for infants with biliary atresia. So I'm going to go pretty quickly through the genetics. I think it'll be interesting, but it is fairly technical, so just want to give you the highlights. And the genetics, genomics has been studied in biliary atresia. We do not believe it's not a Mendelian disorder, such as cystic fibrosis, because there have been many twins born into families with biliary atresia, where one twin will have biliary atresia and the other not. So we don't think it's, strictly speaking, an inherited disorder. We think it's probably more complex genetics, likely multifactorial, maybe something like diabetes, but there may be susceptibility variants that are inherited. And people have often, they've looked hard for toxins and infections, as well as genetics. So the type of genetic studies that have been done in biliary atresia are quite numerous, actually. genome-wide association studies, copy number variants, whole exome sequencing, animal models, in vitro models, and then looking at genetics and clinical outcomes. So the whole genome sequencing has found some susceptibility loci in some groups of patients, and they have found other susceptibility loci in other groups of patients, but always it's only a few patients out of the large cohort that are studied. This is another one, EFEMP1, which is an epidermal growth factor-like gene. There has been a mutation in that gene. But again, it's just a few patients with biliary atresia. ARF6, another one. And then MAN1A2 is interesting because it regulates laterality and ciliogenesis. And so there is a mouse model of biliary atresia that has flipped organs, so situs and versus, meaning that the spleen is on the right, the liver is on the left, and biliary atresia. And this is the gene, MAN1A2, that regulates the formation of biliary atresia in this animal model. But again, it's just a few patients that have these mutations. And there are also rare variants of Alagille syndrome in biliary atresia cases, and other genes related to other causes of cholestasis. Again, quite rare. And so people have tried to see if a mutated gene could be put into a mouse and cause abnormal biliary development. And in fact, that has been done. And it's interesting, I spent most of my career at Johns Hopkins in Baltimore, and we reported that if we develop bile duct cells from the blood samples of children with biliary atresia, they look like you would predict from bile duct cells from somebody with biliary atresia, meaning they don't develop very well and they make a lot of scar tissue. And we're actually using these stem cells right now to see if we can find drugs that reverse the fibrosis that these stem cells show. People have tried to see if there are genetic variants that make a bad outcome or good outcome. And alpha-1 antitrypsin deficiency, which is a common metabolic disease, has also one mutation has been found in children with biliary atresia. So in sum, biliary atresia is not, strictly speaking, a genetic disease, but there are some candidate susceptibility genes that maybe will teach us a lot, both about what causes biliary atresia and then how to prevent it, how to treat it. So that is a quick run through of the findings of geneticists in children with biliary atresia. Now to the second part of my talk, which is looking at novel prognosticators for biliary atresia. And biliary atresia, which is presents with jaundice and pale stools and is shrunken bile duct outside the liver, this is a fairly typical presentation. So on the average, babies have presented to US medical centers at about 2 months of age, which, as we'll see in a moment, is too old of a time, too old an infant for the best outcome. But typically in the United States, 65-day-old female infant prevents for evaluation of elevated serum bilirubin and pale stools. And then an abdominal ultrasound couldn't show a gallbladder. And the liver biopsy showed portal fibrosis. Already, the baby's only 2 months old, bile duct proliferation, and bile duct plugging. The patient underwent operative cholangiography, and the surgeon injected dye or tried to inject dye into the remnant of a gallbladder, and the dye did not go into the intestinal tract the way it's supposed to. And so a Kasai portoenterostomy was performed, which is the surgeon pull a loop of jejunum up to the cut surface of the liver. That's the typical case. So biliary atresia is such a devastating disease, such a rapidly scarring liver disease, that it is by far and away the most common indication for liver transplantation in children at any age, particularly in young infants. Much more common than something like hepatoblastoma, which is a form of liver cancer, idiopathic acute liver failure, or total parenteral nutrition associated liver disease. And even if you look at transplants for all solid organs, biliary atresia is the most common indication in infants under a year of age. If you look in the older children, 0 to 17 years of age, biliary atresia is still the leading indication, far ahead of the second most common cause, which is hepatoblastoma. And again, if you look at all solid organs, biliary atresia is the most common indication. So in this portion of my talk, we're going to review predictive markers that identify patients that would benefit most from the Kasai portoenterostomy, from bringing this loop of jejunum up to the cut surface of the liver. And then we want to talk about prognostic markers after the surgery that are associated with the best outcomes. So we'll talk about laboratory tests and imaging, which we know about now, and then in the future, talk about genetics and also liver biopsy findings. So predictive markers. In other words, markers that would identify individuals most likely to benefit from treatment. So this graph is a graph of survival from PLT, primary liver transplant, versus, meaning that the infant who was diagnosed with biliary atresia went straight to transplant, versus biliary external drainage procedure. And you can see that transplant was associated with early mortality. This is the estimated probability of survival on the vertical axis. But then as time went on, years since the initial procedure, 5, 10, 15, the children who had had a primary liver transplant actually had higher survival rates than those who went through the standard procedure that most of us do, which is the drainage procedure, and then later, if necessary, a transplant. So although this is intriguing data, it's fairly controversial. It's very new, published in 2019. And it is just a one-center presentation. So what we really need is a large-scale, multi-center study to see if we can figure out which of these two approaches should be better, so we can counsel families. Well, what about age as a predictive marker? it turns out that age is the age at which the Kasai procedure is performed is a predictive marker. And here's a nice diagram of the Kasai procedure. Here you see the liver and the stomach, the duodenum, and then the surgeon has taken a loop of jejunum to create a biliary drainage loop. And this is called the Roux-en-Y loop, and the procedure is a Kasai hepatic portoenterostomy. Well, this is one graph from one publication, but I should tell you that it's very, very important that the babies come to this Kasai operation as young as possible. So it's very clear that early treatment improves outcome. So SNL is survival with the native liver. And you can see that the infants who were operated on less than 30 days of age actually had a better survival early on, although 30 days and 31 to 45 days, the white line and the gray line really had comparable survival. But the older the children, this yellow line is 61 to 75 days of age. The orange is 76 to 90. The older the baby is when the operation is done, the worse the survival with a native liver, the more likely the child is going to progress to transplant. So we pediatricians, we pediatric liver doctors, try hard to teach pediatricians and parents about the early presentation of biliary atresia, which is jaundice and elevation of the direct bilirubin. And when pediatrician or the parent sees the jaundice, then it's important to draw blood to test for not only total bilirubin, but also direct bilirubin. And if the child has direct bilirubin elevation, then prompt referral to a center where the Kasai operation can be performed is important. And this is just one study that was published a while ago, cumulative survival. In this particular study, surgery less than 30 days actually did not have as good of a long-term survival as a little bit older. But that is an unusual exception. Usually it's the younger the better. And certainly by 45 days of age is ideal. Also, this is kind of an interesting new publication, just 2020, showing that gamma glutamyl transpeptidase, which is usually elevated in babies with biliary atresia, actually turns out to be a predictive marker in that babies that had a high GGT, which is the usual presentation, actually had better survival than those with a low GGT. And the only reason that we can think of this somewhat illogical finding is that GGT is a marker of bile duct proliferation. So perhaps when the Kasai is done and bile ducts proliferate in an attempt to actually use the jejunal loop for biliary drainage, maybe those babies with a lower GGT don't do quite as well. people have tried to look at other findings as a predictor marker of biliary atresia outcome, looking at the gallbladder, so-called triangular sign, which is a ultrasound sign, blood flow under the capsule, the size of the hilar lymph nodes, but none of those so far have really panned out. Now, transient elastography, which we all use to measure stiffness in a whole variety of liver diseases, has also been done in babies with biliary atresia. And people have looked at the relationship between liver stiffness measures and the age before the hepatic portoenterostomy. And it's certainly logical that the older infants who, as I showed earlier, don't do so well with the portoenterostomy, they have more scarring. However, in looking at measures of liver stiffness before surgery, it actually turns out that that stiffness does not predict the risk of a liver transplant before 1.5 years of age. Probably because at least many babies in whom a Kasai is done developed increased bile flow and maybe even have some reversal of the liver stiffness. Well, what about, what I just talked about were predictive markers. So what about prognostic markers, which means a marker that identifies the likelihood of disease progression or a clinical event? And we use these prognostic biomarkers to counsel families and anticipate complications, and also as endpoints in clinical trials. So total bilirubin is clearly a prognostic marker. And this data comes from a large multi-center study called Children's Liver Disease Research Network, and I was a part of this for many years in my role as director of our liver transplant program at Johns Hopkins. And we found that the total bilirubin 3 months after the Kasai was an excellent predictor of outcome. So this is survival, and those infants who had a total bilirubin less than 2 did by far the best, and those that had one greater than 6, 3 months after the Kasai did the worst, and 2 to 6 was in between. So this is the survival distribution and survival probability, and then it turns out that the difference between less than 2 and greater than 2 is very significant. So what about total bilirubin plus albumin? Well, this is a group 1 that had low total bilirubin and albumin greater than 3.5 milligrams per deciliter, in other words, normal values, and they did the best. And those that had a high bilirubin and a lower albumin did not do so well. Well, can we refine this data any more? Well, if you look at the difference between very low bilirubin and low bilirubin, it looks like those that had very low bilirubin did the best, and those that had a bilirubin less than 0.7 still did very well. What about serum bile acids? So in infants who had a total bilirubin of less than 1.5, 6 months after the Kasai procedure, it turns out that serum bile acids were also quite helpful. So those that had elevated serum bile acids, which is this bar, had a lower transplant-free survival than those who had a low serum bile acids. Well, MMP7 is a new diagnostic test for biliary atresia. It's a blood test, matrix metalloproteinase. This was developed by Georgie Becerra and group at Cincinnati Children's. And it turns out that this is a great way to diagnose biliary atresia in young infants with jaundice. And then also, in this case, the MMP7 levels after hepatic portoenterostomy turned out to be highly predictive of outcome. So those babies that had a MMP7 level greater than 10.3 had a much greater likelihood of transplantation than those who had lower levels. And then even though liver stiffness before the Kasai didn't predict outcome of the Kasai, it turns out that liver stiffness after the Kasai is predictive of outcome, which makes sense. So as liver stiffness increased after the surgery, this became a predictor of outcomes. So this is a summary of Dr. Harpavat's very nice talk. The best predictive marker is the age at Kasai portoenterostomy. So for the pediatricians in this webinar, early referral of a jaundiced infant to a center where the diagnosis of biliary atresia could be made quickly, and if their biliary atresia is suspected, the surgery be done. That's the age at the Kasai portoenterostomy is the best, ideally before 45 days of age. In the future, we may see that some of these genes that I talked about will predict outcome. The findings of the liver biopsy at the time of Kasai, maybe some imaging that we're not doing now. And of course, if we knew what the best predictive markers of success of the Kasai were, then also we could avoid operating on babies who wouldn't benefit. Maybe those babies should go straight to transplant. The best prognostic marker, in other words, how the baby did after the Kasai procedure, is still the total bilirubin, as I shared with you. A total bilirubin less than 2, 3 months after the Kasai is an excellent prognostic marker. And in the future, it may be that serum bile acids, MMP7, liver stiffness will be excellent prognostic markers. And of course, in order to know the prognostic markers and the outcome of clinical trials, we have to be able to subdivide infants who are likely to do well anyway after Kasai or who are not likely to do well, would be the best trial design. So then I will spend my last 15 minutes or so talking about long-term outcomes of biliary atresia after the Kasai operation, including some hopeful new solutions for better outcomes. And this is Saul Karpin's talk. So we'll talk about outcomes during childhood, also talk a little bit about what is it like to be an adult with biliary atresia, and again, what are the potential therapies. So outcomes during childhood. So you remember the earlier case of the typical 2-month-old baby who is diagnosed with biliary atresia and so has a Kasai, which would be at roughly 60 days of age, and it drains, so the total bilirubin, which was high, decreases, and that would be a success because by age 2 years, the bilirubin is normal. However, even as early as 6 years of age, the child has developed portal hypertension. So the normal white count is 5,000 to 10,000. This baby had a white count that was depressed at age 6 and very low platelets. Platelets should be 150,000 or more. Increased liver enzymes, about twice the normal. And the gamma GT, which for a 6-year-old should be about 25, is increased. So, but this, we call this a quote unquote successful operation. And at age 8, an MR showed this very large spleen, and you can see that here. And you would predict it from the low platelet count. At age 9, the white count has fallen further, the platelets have fallen further. Interestingly, the GGT has fallen a little bit, and the albumin is starting to fall. So this child had a liver transplant appropriately at age 9 because of all these signs of liver failure, and you can see when the liver was removed, it was very nodular and cirrhotic. So the French have published a lot on biliary atresia, and here is their data, survival of the native liver after the Kasai procedure. So in the first 2 years, about half of the children get transplanted or die. It's a very rapidly fibrosing disease. And then at 5 years of age, those children that survive to 5 have about a 40% chance of survival of the native liver, and so on. At 10, it's down to 35%, 15, 30, and at 20, when the child enters adulthood, only 25% of children who are born with biliary atresia make it to age 20 with surviving with a native liver. And it seems like the discriminating age is about 2 years. So survival with the native liver declines rapidly during the first 2 years. And then if the child makes it to age 2 without a transplant, there is a less of a chance of transplant, or I should say more of a chance of survival with a native liver. This is the Cincinnati data, and looking at the bilirubin at 3 months post-Kasai, less than 2 or greater than 2, and in about half of the babies fell in each category. So those that had a low serum bilirubin 3 months post-Kasai had a much higher chance of survival with a native liver than did those who were jaundiced. And those who were jaundiced had 79 to 93% chance of having a liver transplant at that point. Now, the serum GGT levels at age 2 also turned out to be predictive. So if the serum GGT is greater than 100 at age 2, that predicts worsening thrombocytopenia, worsening decline in platelet count. So a GGT less than 100, the platelet count stayed pretty normal up to age 6, whereas those that had a high GGT at 2 years of age had a declining platelet count. Sorry. So people have tried to model survival without a transplant, and they've looked at total bilirubin, the history of ascites, history of cholangitis, albumin, platelet count, and predicted transplant survival at age 7. And if all those things are normal or absent, then the transplant-free survival is almost 100%. Whereas if you look across these risk groups, those that had increased bilirubin, history of ascites, history of cholangitis, falling albumin, falling platelets, about half of them had a risk of transplant. This was a way to look at sentinel events, GI bleeding, ascites, and portal hypertension. And it turned out that the platelet count and the GGT were predictive of this kind of trouble. The lower the platelets, the more likely the patients were to have a bleed or ascites, and the same with the GGT. Well, what about adult outcomes? This was a report from France of 63 patients who survived for over 20 years with their native liver. So they made it to age 20, and then people looked at what happened to the survival. And still after age 20, the survival continued to dwindle. Almost all of these patients were cirrhotic. 2 died of acute liver failure, and 10 underwent a liver transplant. So it is a problematic disease, even for those who survive for over 20 years. And this is similar data from an Italian center, 18% survival with a native liver at age 20. And then, of course, in adults over the age of 20 who have survived with biliary atresia, there is a risk of decompensated liver disease. And then, although there certainly are subjects with biliary atresia who have made it through successful pregnancy, these patients are high risk, and they do have an increased risk of hepatocellular carcinoma. This was a compilation from 5 different series: biliary atresia, survival with the native liver after age 16. 3/4 had clinical cirrhosis, most of whom had portal hypertension. About half had varices, and itching was a problem, cholangitis was a problem, and 40% of these subjects were on a wait list for a liver transplant. Well, let's close with some happy news. What about therapies? Well, people have looked at various different ways to stimulate bile flow, including FXR activators, bile acid transport inhibitors, bile acids that stimulate bile flow, such as ursodeoxycholic acid, and also FGF19, which controls bile acid synthesis. And then there are some non-bile acid based therapies that have been proposed, antifibrotics, gene-specific correctors, steroids for anti-inflammatory. So those have been discussed for various investigators. Those that have actually been used include steroids, antibiotics, ganciclovir for cytomegalovirus, because there are a few babies that have with biliary atresia that have cytomegalovirus, and but whether or not these have been put to placebo, properly done, large-scale randomized controlled trials is quite rare. But I will share the one randomized controlled trial of steroids that we did. And then the clinicaltrials.gov there are 2 new therapies for biliary atresia that are ileal bile acid transport inhibitors, IBAT inhibitors. And we are starting the odevixibat trial at Rady Children's this week, in fact. So this was our Children's Liver Disease Research Network large-scale randomized controlled trial of steroids, high-dose steroids or placebo right after the hepatic portoenterostomy, and then looking at survival with the native liver. And there was no difference, placebo versus steroids, in terms of the outcome, but there was a difference in side effects. So the steroid-treated babies had an earlier time to develop serious adverse events, and they had impaired growth. So, and then various adjuvant therapies have been looked at in terms of percentage clearance of bilirubin, and there's no difference. So what about what we're doing now? Well, this is why we're so anxious about this disease. This is a 3-month-old baby that already, with biliary atresia, that already has cirrhosis. We have to intervene early. This is the Kasai procedure with the liver and the loop of jejunum, and bile acids are absorbed in the terminal ileum. Well, we know that because there has been impaired bile flow, the liver of the baby with biliary atresia has very high amounts of bile acids. And bile, of course, is a digestive fluid, so it digests fat. That's a good thing. But if the bile acids are retained in the liver, of course, the liver gets digested and scarred, and then cirrhosis develops. So these trials that are brand new, just starting now within the last few months around the world, are 2 different drugs that actually inhibit the absorption of bile in the ileum. So they are the BOLD study, which is we're starting, and the EMBARK study. And here is the cecum and the ileum and the ileal bile acid transporter, and the drugs inhibit the reabsorption of bile back up into the liver. And what do we know so far? Well, we know that the long-term outcomes of biliary atresia, age, the earlier the age the Kasai is done, the better. We know that total bilirubin of 2-3 months after the Kasai is helpful. And we think it's very important to focus on growth and fat-soluble vitamins. The outcomes during childhood up to age 18, there's only about 25% survival with the native liver, and These babies are at risk for cholangitis and portal hypertension and cirrhosis, and even liver cancer has been reported in a child with biliary atresia as young as 3. And as I showed you, the GGT and platelet counts are helpful to prognosticate outcomes during adulthood, greater than 20 years of age. The vast majority are cirrhotic, and then there are ongoing concerns for cholangitis. And the current therapeutic landscape, steroids don't work. Ursodiol has actually never been tested in randomized controlled trials, but we all do use it. And the hope is that these 2 new IBAT inhibitor trials with the goal of decreasing intrahepatic bile acid accretion will have better outcomes, because the pilot studies from these trials are quite encouraging. So I believe that is, this is my last slide. Biliary atresia is a cholangiopathy from multiple potential developmental causes. There's some no known etiology, but we think there are some genetic hints. It's the #1 cause of neonatal cholestasis, the #1 cause of indication for pediatric liver transplantation, and the total bilirubin is certainly helpful. We recommend referral of a baby for direct bilirubin with greater than 1 to a center for workup very promptly within the first 3 weeks of life. And the total bilirubin 3 months after the Kasai does indicate outcome. Okay, I believe I can stop there and ask if there are any questions.
Wonderful, Dr. Schwarz. Thank you so much. That was really informative. As someone who does adult primary care, I don't see this a whole lot, so I learned a ton today. We do have we have a comment and a question. The comment, this attendee is sharing their experience, so I'll read what she wrote. She said, in case this is helpful for your data, my daughter had biliary atresia. When her liver enzymes were abnormal and the scans and biopsies could not identify the source of her liver problem, we were told it's better to have exploratory surgery before she's 3 months old in case a Kasai procedure was needed to be done, because before 3 months old, it improved the chance of it being successful. She had the exploratory surgery at 11 weeks old, and they found that she had biliary atresia and did the Roux-en-Y. About a month later, she was hospitalized with cholangitis, and we were told that the Kasai did not work and she would need a liver transplant or she would die. She had a liver transplant when she was 8 months old, which was over 29 years ago now. So thank you for sharing that.
Well, thank you very much for sharing that. And I have to say that the first child that I ever diagnosed with biliary atresia, I diagnosed in 1982. And that child is now in her 40s and is a articulate advocate for biliary atresia research, and she's a mother. She calls me every Mother's Day. So thank you for sharing. I'm so glad you had a good outcome of transplant.
And that actually is a nice segue into the other question she had, which I was wondering about too. So she says, what information do you have about biliary atresia being hereditary? My daughter had it, and when she has a child, will her child have an increased risk of biliary atresia as well? And I wanted to tag on to that because I was wondering the same thing. I know you said it's not Mendelian, we don't understand it a whole lot, but I'm wondering if you do see family clusters.
So thank you very much. If I didn't make it clear, it is not hereditary. So your daughter, when you become a grandmother, your daughter who had the transplant does not have any increased risk of having children with biliary atresia. However, these various genes that have been, these mutations that have been found in a few children with biliary atresia, and it's a growing list of genetic mutations, they probably put the baby at increased risk for some kind of insult. Maybe it's a toxin, maybe it's a virus, maybe it's something else. So I guess the exciting thing is, from your daughter's standpoint, is that there is a great deal of active research to try to figure out what these genes mean, both in terms of therapy and predicting response to surgery.
Thank you for that. And then I think that's all the questions we have from the audience, but I did have a couple questions myself too. I was curious, because I know that this is a fairly rare disorder, but how many babies do you see with this in a typical year at Rady's?
Well, I can answer that directly because we've looked for the last several years. We see about 6 a year at Rady's. And the incidence of biliary atresia is 1 in 20,000 in the United States. It's a little bit more common in parts of Asia, and it's more common in Japan and China. So people have looked at genetics and diet. In my career of taking care of children with liver disease for the last 40 years, I have probably cared for maybe 150 children with biliary atresias. So it's one of these diseases that, although it's fairly rare, we try very hard to educate family practitioners, pediatricians, nurse practitioners about the disease, because we believe that we really can make a difference in outcome with both early Kasai and, if necessary, transplant.
Thank you. And then one other question I had was, for children who do survive with their native liver for a period of time into later childhood and adolescence, are there issues as far as nutritional deficiencies and inhibited growth or anything like that?
So that's an excellent question. Of course, bile is necessary for the absorption of the fat-soluble vitamins. So children with biliary atresia are at increased risk of deficiency of vitamin A, D, E, and K. And in fact, we proactively supplement those fat-soluble vitamins in babies just after the Kasai procedure. And we do, even the children who are doing quite well, we still monitor the blood levels of those vitamins at least once a year. And then cholangitis is a monster for us, because I have had children who have supposedly been doing very well after the Kasai for many years, including into late adolescence, and then developed cholangitis because, as you saw, the loop of jejunum is, of course, wide open to the intestinal tract. So if bile goes down that loop of jejunum, then bugs can go up the loop of jejunum. And I have seen one child I particularly remember, who I think was a sophomore in college, who ignored the fever that she had because she was a busy sophomore, and she had the fever for a week and came into the emergency room, and she was in shock from E. coli, sepsis, and cholangitis, and she has now been transplanted. So even though we're always thrilled when a child does well, we still follow them very carefully for these complications.
That all makes sense. Thank you so much. I think that's all the questions we have. I'm still checking the chat pod, but I don't see anything else. So I think without further ado, we'll end it. I want to thank everyone for participating. And thank you again, Dr. Schwarz, so much for your presentation. That was wonderful.
It was a pleasure. Thank you very much for inviting me.
Absolutely.